Dr. Kakamad from Suleimani in Iraq. He will talk about the dry chest tube, an alternative approach to minimize postoperative air leaks, and that's a randomized control pilot trial. So, Dr. Kakamad.
Good evening. I am H.Kakamad from Iraq, Christian region. I have no disclosure. Postoperative prolonged air leak is typically defined as an air leak that persists for more than 7 days. It increases postoperative morbidity and mortality. Even with capitonage, as we know, prolonged air leak could occur in 4 to 9% of pulmonary hydatid cyst resection. Management strategies may vary depending on the severity, duration of the leak, and ranging from conservative observation to surgical intervention. One of the minimally invasive methods, as you know, is the autologous blood patch. It's simple, safe, and cost-effective. What's the idea is to elevate the tube of the patient about 1 meter above the bed, so it will let the blood, few cc of blood, remain in the chest cavity. So at the beginning, just directly after the patient recovers from general anesthesia, when we are sure the patient's condition is stable, and the patient is okay, so we will elevate the tube. So we'll let the air to come out, escape, while the blood remain inside to act as a autologous blood patch. Inclusion criteria: patients diagnosed with a pulmonary hydatid cyst for 4 years were included. With a risk factor, we didn't include all the cases of pulmonary hydatid cyst. We just include those cases that increased risk factor for developing prolonged post-operative air leak. So they are central hydatid cyst, ruptured one, giant one, and poor pulmonary function, patient with steroid or immunocompressive drugs, and redo operations. When we avoid usually this procedure, when we have a pediatric age group, we haven't tried. When we have hemostasis uncertainty, almost all surgeons inside the operation, we have some feeling that the patient might develop postoperative bleeding. At that time, we abort the protocol. Also, in the postoperative period, when we have a suspicion of bleeding, again, we don't do it. We habitually learn the staff that following up with the patient that any increase in heart rate is a red line, please. At that time, we'll put the tube on the ground. So the patient, almost all of them, not almost, underwent biport VATS capitonage with insertion of large bore chest tube to avoid blockage of the chest tube. So the patient randomly assigned it into 2 groups. Group A, control group, is just routine follow-up, while the group B, those patients, they underwent dry chest tube. We found that there were 30 patients in each group, and the average air leak was 6 days for group A, while 4 days for group B. The p-value was significant. Average duration of hospital stay was 7 in group A and 5 in group B. Also, again, p-value was significant. There was some minor complication we observed more in the test group or group B. Subcutaneous emphysema significantly higher in the test group. Peri-tube leak at the beginning of the trial was high in the second group, but lately we learned that a tight chest tube prevents this complication. Oxygen saturation was not so significantly different. There are, of course, limitations of this study. First is small sample size. Second is the population of the study. Ideally, this idea might be best for study to be applied for operations like volume reduction surgery or decortications. So the population might not be ideal for hydatid cyst, although we have suffered as a developing country, suffered from also air leak after post-operative for pulmonary hydatid cyst. So in conclusion, dry chest tube may decrease the duration of air leak in high-risk patients for this study in hydatid cyst. However, further studies with a larger sample size is needed to confirm the finding also in other population, as we mentioned. And last is our home, Smart Health Tower. Thank you.
When you do this, it's like if you clamp the brain.
So you don't clamp, you just...
But it's the same, because you see the level is very high.
Okay.
Pressure is very high. It's like if you clamp the brain and if you have one problem, you take that.
We don't clamp to let the air come out, for the air. The air,
The pressure very, you do the pressure very high, the pressure will be, the air can go up. It's why you have this together.
could be the air is not easily go out, but if you clamp it, you will stop 100%. At least clamp elevating prevent tension pneumothorax. At least, you know, it will not be. But in clamping, there might be a tension pneumothorax.
Right. It's why you must choose very well the patient that
You're right.
or will have big problems after.
You're right.
And when he began to cough and all this, your fistula can open and you have more problem. It's very good, but you must choose very good the patient.
Yes, selection is a big issue. Really, in my practice, I'll do this routinely for all cases with a suspicion of prolonged air leak. But our population is larger with hydrosis. That's why we did the trial on hydrosis. Otherwise, we'll do for all cases when we have a risk of prolonged air leak. As you said, yes, with a good selection and a very tight follow-up. Very tight. Yes, you are right, definitely. It's a governmental hospital, to be honest with you. Yes, you are right. But in a private hospital, it's just like Europe. And you have friends here, might be, they have operated in our hospital, I think, someone said. Yes, they said it's just like Europe in a private hospital.
Last question. Nice presentation from the video. I've got only one doubt, that does it happen that once you do this, there is clot formation inside and that might hamper later on with the drainage once you put it right?
No. You know why? We haven't observed this kind of complication. Why? Because we're following up the patient with a heart rate. Any increase in the heart rate more than 10 degrees, we'll usually put the tube down so it will let the blood come out. Roughly about 500 cc of blood loss will affect the heart rate. So till now, for the last 4 years, we haven't a complication like that really.
سمارت ورشرخانة